Yeah, yeah.
Thank you, sir. You may proceed further. Over to you, sir.
Okay. So, very good evening to everyone. I am Dr. Murugeshan. I am assistant professor in neonatology in JIPMER, Pondicherry. So, today's topic is neonatal sepsis. So, sepsis, as we all know, it's a very important topic, both from the academic point of view as well as from the clinical point of view. So, we will briefly cover about how to identify a neonatal sepsis and what are the usual causative agents. What is a sepsis screen? How do we do that? And how do we treat neonatal sepsis? So, coming to the definition, neonatal sepsis is a clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. So, this accompanying bacteremia is usually diagnosed by blood or CSF culture. So, it need not be positive all the time because the cultures have usually a low yield. So, even if clinical symptoms are fitting, we can call it culture negative sepsis. So historically, it is classified into early and late onset sepsis. Early onset sepsis is onset within the first 72 hours of life. Anything which has onset of the if there is an onset of infection 72 hours or more from the day of birth, it is called late onset sepsis. So early onset sepsis usually is related to complications of pregnancy or delivery. The source of organisms usually from the maternal genital tract or from the labor room or from the birthing areas, right? So late onset sepsis can be both from the environment as well as rarely from the maternal genital tract also. So the usual clinical presentation in early onset sepsis is it is multi-system involvement, right? Baby will have a florid signs of sepsis and pneumonia is very common because the infection is acquired by the baby during the process of delivery. So it is inhalational, so it affects the lungs, right? In late onset sepsis, usually we have a foci. It is like sometimes we get meningitis, sometimes we get septic arthritis, sometimes we get umbilical infection, omphalitis, right? So it's usually localized. And the mode of transmission in early onset sepsis, it is during delivery or from mother to baby or intrapartum. Late onset is usually horizontal or nosocomial. So it is important to know what is early onset and late onset so that we can uh, anticipate sepsis based on the risk factors and treat accordingly. So these are risk factors for early onset neonatal sepsis. Of all the risk factors, the most important risk factor is prematurity because of their poor immune system, low birth weight, and clinical chorioamnionitis. So chorioamnionitis is nothing but infection of the placenta or intrauterine infection. So clinical chorioamnionitis means mother should definitely have a fever. It is a mandatory criteria. Plus, there should be some other signs like maternal tachycardia, fetal tachycardia, maternal TLC more than 15,000, and foul smelling liquor and uterine tenderness. So fever plus any two of these five criteria, if it is there, we will call it clinical chorioamnionitis. And another risk factor is prolonged rupture of membranes or rupture of membranes for 18 hours or more. And prolonged labor, which is 24 hours or more, foul smelling liquor, single unclean PV examination, or three or more, even sterile PV examination. Right? So it is important to ask for these history in any mother or look through the case sheet of the obstetric case sheet of the mother, or in case of outbound deliveries, it is important to ask the history from mother. Right? So history of fever is also important because clinical chorioamnionitis we can diagnose by fever and the other criteria. So coming to late onset sepsis, here we all know the infection is acquired horizontally or after delivery. So this is a major concern, right? Early onset sepsis may be from the mother. So mothers may come from prolonged PROM, which is not totally under the control of the treating physician. But late onset sepsis, there is a lot of scope for prevention, right? So most often late onset sepsis risk factors are frequent invasive procedures, poor skin integrity, frequent handling, repeated courses of antibiotic therapy, NICU understaffing, and hand washing, lack of hand hygiene adherence, right? And also poor nutrition, like delayed initiation of enteral feeding, long period to reach full enteral feeding, and lack of breast milk feeding, right? So basically, if we have to prevent late onset sepsis, we should try to focus on giving adequate nutrition, that is enteral nutrition with the mother's own milk, and avoiding frequent invasive procedures and frequent handling of the baby, and emphasis on hand hygiene. If we take care of these things, most of the late onset sepsis can be prevented. So coming to the clinical features, so we just saw early onset sepsis. The presentation is more like systemic, with almost most of the babies will have pneumonia. Late onset sepsis, it is usually localized. So we have to think of symptoms in a newborn baby, which can be systemic and local. So we can divide into system wise. For example, general symptoms in any baby with sepsis will be poor feeding, poor cry, poor weight gain, abdominal distension, vomiting, or shock and bleeding. So these are the general symptoms. Specific to pneumonia, baby will have cyanosis, tachypnea, retractions, grunting, or apnea and gasping. In meningitis, baby may have seizures, high pitch cry, excessive irritability, neck retraction, bulging AF. Right? So if there is any GI infection, in addition to the general signs, we saw abdominal distension, vomiting, there may also be loose stools. Right? So there is something called scleroderma. Scleroderma is nothing but diffuse hardening of subcutaneous tissue, especially the fat, and results to very tight skin. Right? Scleroderma is usually a manifestation of disseminated inflammatory response. Right? So all these inflammatory cytokines will be released, and the fat in the subcutaneous tissue, there will be deposition of this plasma proteins, which will give the appearance of hardening of skin. It usually starts in the cheek first and then to the rest of the body. If any baby has scleroderma, then it is a manifestation of severe sepsis. Okay. So renal failure can be there because of sepsis being a multi-system involvement. So cytokine release and injury will also cause AKI or acute kidney injury, which will manifest as renal failure. So to summarize, there will be some general symptoms and some system-specific symptoms, which are usually non-specific, and all these symptoms can be seen in other illnesses also. So we should always have a high index of suspicion whether it could be due to sepsis, right? So now we know the risk factors for early late onset sepsis. We know the symptoms. So now we have to diagnose sepsis. How do we diagnose? So we take into account the risk factors, clinical features, and we have some diagnostic tests. So the gold standard, as we all know, is isolation of microorganisms from blood, CSF, urine, or pus. So by culture. But culture usually has a lesser yield, like only 10 to 15% of babies will have culture positive. So in other cases, usually it is culture negative. So if clinical features are strongly suggesting sepsis, blood culture should be taken and antibiotic should be started. Right? We should not wait for supportive evidence. So clinical features, if they are strongly suspect suspicious of sepsis, we should start antibiotic after taking blood culture. So blood culture is the gold standard. It should be performed in all episodes of sepsis prior to starting antibiotics. A positive blood culture along with sensitivity pattern of isolated organism is the best guide to antimicrobial therapy. So always make sure we do adequate skin preparation, collect at least 0.5 to 1 ml of sample for blood culture. So we have some indirect methods of diagnosing. One of them is sepsis screen. So it is a combination of laboratory parameters. So the name itself suggests sepsis screen. So screening is only for otherwise well baby, but who have some risk factor for sepsis, and we are not really sure whether it is sepsis or not. So in that baby, you are going to perform a sepsis screen. Sepsis screen is not needed if the baby is sick looking and you have decided to start antibiotics anyway, right? So especially in early onset sepsis, when there are risk factors in the baby, like maternal fever, if there is prolonged rupture of membranes, if there is spontaneous preterm labor, or if there is PROM, or if there is UTI in the mother. So then if there are two or more risk factors in an otherwise well baby, then we do sepsis screen. Okay. So what are the components? We have 5 components, namely TLC, ANC, IT ratio, which is immature to total fraction of uh, leukocytes, micro ESR, and CRP. So the abnormal values are given here. So TLC less than 5,000, ANC less than 1,800, IT ratio more than 20% or 0.2, micro ESR above 15, and CRP more than 10 milligram per liter or 1 milligram per deciliter. So be careful about the unit. So micro ESR is done by taking a 10 centimeter capillary tube and filling it with blood. Then you allow the capillary to stand for 1 hour. Then you measure the amount of serum which is standing on top of the blood column. So that is measured in millimeter, right? So it is a bedside test only. So if two or more parameters are abnormal among these 5, then we call it as sepsis screen positive. So that newborn, we may have to start antibiotics, even though sepsis screen, the sensitivity and specificity are not very great, but we should always suspect infection in a baby with sepsis, positive sepsis screen. As we discussed, it could be positive due to other reasons also. Some of the reasons are SGA, IUGR baby. So in all these babies, it may be falsely positive. So lumbar puncture, which babies do we need to do a lumbar puncture? So in early onset sepsis, if the baby has clinical features of septicemia, widespread infection, or symptoms of meningitis like seizures, or if the blood culture is positive, then we have to do. If we are starting only for risk factors in the mother, like chorioamnitis or PROM, then we need not do a lumbar puncture. We will still take a blood culture, but we won't do lumbar puncture. So in case there is late onset sepsis, so we should do LP for all babies with late onset sepsis, right? So in early onset sepsis, we are going to do only if blood culture is positive or if clinical picture is suggestive of widespread infection or meningitis. In late onset, we should do for all the babies. So coming to the management, so in any newborn emergency, the management starts with TABC, temperature, airway, breathing, circulation. We have to maintain normal SpO2 between 91 to 95, maintain normal sugar, give vitamin K 1 mg, and if the baby is in shock or hemodynamically compromised, then you withhold feeds. Otherwise, you start orogastric feeds as soon as the baby is hemodynamically stable. If there is sclerema, we may consider exchange transfusion. Right? Sclerema, like we discussed, is a form of disseminated sepsis. So we may consider exchange transfusion in sclerema. So after supportive management, of course, we are going to initiate broad spectrum antibiotics also. In fact, we will initiate it side by side. So antibiotics and supportive management go hand in hand, right? So broad spectrum antibiotics should be chosen based on the unit's previous antibiogram. So every unit should keep track of the cultures they are sending and what reports they are getting. So based on the culture and sensitivity patterns, broad spectrum antibiotics should be decided for the unit. So empirical upgradation may be considered if there is no clinical improvement by 48 hours of antibiotics or if the condition is worsening. We have to give at least a few hours time for antibiotics to work, right? So we usually wait at least 48 hours to see response for antibiotics. Or if we get a culture before 48 hours, which is showing some other organism which is sensitive to another antibiotic, then we can escalate. So we need not measure serial CRP in a otherwise well baby just to escalate antibiotic or de-escalate antibiotics. Right? Though CRP is part of sepsis screen, we need not use it for taking decisions for duration of antibiotic therapy or for change of antibiotic therapy. So another important thing is once we know whom to start antibiotics, we also need to know whom we should not start antibiotics or whom antibiotic may be unnecessary or we may end up doing unnecessary investigations for sepsis, right? So just because somebody has meconium stained amniotic fluid doesn't mean we have to work up for sepsis or consider antibiotics. Meconium aspiration syndrome, respiratory distress, perinatal asphyxia, asymptomatic neonates with only one risk factor for UOS, and jaundice, just because baby is preterm, cyanotic heart disease, all these conditions, routine workup for sepsis is not needed, right? And most important thing, when to stop antibiotics. Suppose the culture comes negative, then we look at whether the baby was symptomatic or not. Suppose we had started the baby on antibiotic only for risk factors in the mother, especially in the case of early onset sepsis. If mother had chorioamnionitis, mother had PROM, mother had foul smelling liquor, and you have sent culture and started the baby on antibiotics, you can stop as soon as the culture comes sterile because this baby is asymptomatic, right? So in a symptomatic neonate or with positive sepsis screen, we usually continue antibiotics for 5 to 7 days if culture is sterile. If culture is positive, we usually give for 10 to 14 days. 10 days is typically reserved for some gram positive sepsis like especially group B streptococci or coagulous negative staph. 14 days is usually given for all gram negative septicemia like E. coli, Klebsiella. So in meningitis, we usually give antibiotics for 21 days. So there is something called antimicrobial stewardship. So what is antimicrobial stewardship? So antibiotic, if you are to tell in a nutshell, it is giving the correct antibiotic for the correct patient for the correct duration, right? So that is antimicrobial stewardship. So timely and appropriate antibiotic utilization and appropriate selection, correct antibiotic and correct dose, route and duration. So that is called antibiotic stewardship. So these principles should be applied not only for treating sepsis, but also for giving empiric antibiotics to those with risk factors also. So we should stop timely and start timely and give for optimal duration without giving unnecessary or excessive antibiotics. At the same time, we should not give lesser duration of antibiotics for serious infections also. Okay, coming to a few case scenarios. I think everybody can participate. You can type your answer in the chat box also. So antibiotic cannot be the answer to all the queries. So there are some conditions which may look like sepsis, but they are not sepsis. So we should know how to differentiate. Okay, so this is case one. This baby is 38 weeks of life, 38 weeks of gestation with 2.85 kg birth weight, vaginally delivered. So born at 12/9/2022, time of birth is 11:30 p.m. So mother is first time mother, primiparous, booked pregnancy. There is history of meconium stain amniotic fluid. There is no risk factor for sepsis like maternal risk factors. Baby cried immediately after birth. Apgar score is normal. Baby is admitted to SNCU or NICU because of respiratory distress. So TABC, remember the first thing is TABC. Then you start on CPAP. Baby is maintaining saturation on CPAP. So what should we do next? Should we send sepsis screen? Should we start antibiotics? Should we give feeds? Should we start antibiotics? Can you just reply yes or no? No, no. Okay, very good. Aishwarya, Sahana, no. Okay. So what is the diagnosis for this baby? This baby probably has meconium aspiration syndrome or transient tachypnea of newborn, right? So it is usually a self-limiting condition. There is no maternal risk factor for sepsis. Baby is maintaining on CPAP. So you can continue to observe the baby. If any time you have doubt of sepsis, then you go ahead and do sepsis screen. But as such, this baby need not require IV antibiotics or sepsis screen, because you remember one of the risk factors for late onset sepsis is frequent sampling and breakdown of skin integrity. So even if the baby is not septic, we may introduce infection by all our sampling and other procedures, right? So this baby can be started on OG tube feeds only because baby is hemodynamically stable. So antibiotics were not required for this baby, and baby is just being monitored for respiratory distress, right? So this baby was ultimately weaned off to room air by day 5, discharged on day 8 of life. So the take home point is all neonates, just because they require admission to NICU, do not require a septic screen. And antibiotics are not required in all the cases, right? And meconium stained amniotic fluid or meconium stained liquor or meconium aspiration syndrome usually does not require routine antibiotics, right? Okay. Now we will see another case scenario. This is of a preterm baby. So this baby is 32 weeks of gestation, 1480 grams birth weight. So it is a VLBW baby, born at August 10th, 2022. Time of birth is 10 a.m. So it is a gravida 2 mother, unbooked pregnancy, received 2 doses of antenatal steroids. Mother has leaking PV for 48 hours. TLC count of the mother is 18,800. Right? Remember, in the definition of clinical chorioamnitis, we discussed maternal fever is mandatory, plus any two of the 5 criteria should be satisfied, like maternal tachycardia, fetal tachycardia, foul smelling liquor, uterine tenderness, and TLC more than 15,000. So this mother has a TLC of 18,000, right? And at birth, baby cried immediately. Apgar score is 6 and 8, 1 and 5 minutes. So baby shifted to NICU because baby is very low birth weight and has respiratory distress, right? On transfer to NICU, baby is, again, we are doing supportive management, TABC, secretions cleared, started on CPAP, baby is maintaining saturation, right? Heart rate is normal, CFT is normal, pulses are palpable. So this baby, what should we do next? Should we do sepsis screen? Yes, no? Yes, yes, Sahana, Shisuruda, Harshita, yes. So everybody agrees sepsis screen is a must in this baby. Because even though baby has respiratory distress, and it could be very well explained by respiratory distress syndrome or RDS, the baby also has maternal risk factors, right? Mother has leaking PV, TLC count is high, so we have to perform a sepsis screen. So there are two risk factors in this baby. Sepsis screen is performed, TLC normal, ANC is normal, CRP is normal, IT ratio is alone positive, micro ESR is negative. So only one is positive out of 5. So the sepsis screen is negative. So should we start antibiotics? Should we start feeds? So since sepsis screen is negative, we can just monitor. In case baby has any worsening clinical symptoms apart from the respiratory distress, we may consider if the baby becomes sick. But at this point of time, it is not required. So baby was monitored on CPAP, weaned from CPAP on day 9, on room air from day 10, started on full OG tube feeds only because baby's VLBW are less than 1.5 kg. We are starting 80 ml per kg per day. And baby is on full feeds by day 5. In the supportive care, KMC is also important because TABC, temperature, includes kangaroo mother care also. So mother's own milk has been started and baby is regaining birth weight by day 8 and discharged by day 16. So the important learning point is, if there is maternal risk factor of sepsis, especially in a preterm baby, if 2 or more factors are there, then do a sepsis screen. If it is negative, you can wait. Not all preterm neonates require antibiotics just because there are some risk factors. If there are Clinical symptoms which are suggestive of sepsis like shock or something, then we may consider. But just for respiratory distress and one risk factor or two risk factors, we need not start antibiotics. We can do a sepsis screen and then decide. Coming to case 3, this is again a preterm VLBW, 31 weeks, 1.399 kg. Obstetric history, primiparous mother, unbooked pregnancy, 1 dose of antenatal steroid. They have done LSCS in view of antepartum hemorrhage. So mother has fever for 2 days, TLC count is high, history of foul smelling liquor. So this classifies as clinical chorioamnionitis. Fever plus 2 criteria are met. TLC is high, foul smelling liquor. So baby did not cry at birth, right after initial steps. Abgar is okay. Shifted to NICU for respiratory distress. Again, we are doing TABC and supportive management. Baby has cold stress, so we are rewarming the baby. Airway and breathing, we are taking care by CPAP. SpO2 is normal. The baby also has heart rate 176, CFT more than 3 seconds, pulses are poor, and required one saline bolus of 10 ml per kg. So what should we do? Should we straight away start antibiotics and take culture, or we should send sepsis screen and wait for this baby? Send culture and start antibiotics. Okay, good. Anybody feels we have to wait for sepsis screen? Okay, Kirtana Reddy, send culture and start antibiotics. Aishwarya. Okay, good. So we should start antibiotics after taking culture. We can send a CBC, but this baby is already sick, right? So baby has tachycardia, has poor CFT and poor pulses. So this baby is having shock already, right? So even though we send sepsis screen, we are not waiting. And this baby has 3 risk factors. And also, like we discussed, the mother satisfies the criteria for clinical chorioamnionitis and shock. So sepsis screen is also positive. TLC is less than 5,000, ANC is less than 1,800, IT ratio is above 0.2, right? So 3 things are positive. So started on first line antibiotics, culture has been sent. So now comes the question, how long do you continue the antibiotics? So we wait for the culture, right? If sepsis screen is positive and culture is negative, we give for 5 to 7 days. If it is positive, then we give for 10 to 14 days, right? So in this baby, blood culture is negative, so they have stopped antibiotics after 5 days. So what about feeding? Will we start feeding in this baby? This baby has shock, right? So when baby is hemodynamically unstable, we initiate only something called as men feeds or minimal enteral nutrition, which is only minimal feeds like 10 to 24 ml per kg per day. We won't give 60 ml per kg or 80 ml per kg. Men feeds will be given with the IV fluids, right? So the baby is being monitored on CPAP, circulation is being assessed. So CPAP has been weaned from day 8 and in room air from day 9. So initially started at MEN feeds and later hiked as circulation has improved. So baby is on full feeds by day 6. So KMC has been initiated once baby is stable. Remember in the first case and second case, KMC was initiated from day 1, but this baby has shocked, hemodynamically unstable, so initiated later. So breast milk expression has to be told to the mother. Baby is on full mother's own milk by day 6 and breastfeeds by day 18 and discharged on day 22. Right? So here the important learning is identification of early signs and symptoms is very important along with identification of risk factors. So this baby, there was history of clinical chorioamnionitis, 3 risk factors in the mother. Baby had shock, poor pulses. So that clinical signs and symptoms are very important. And supportive management is of utmost importance in case of shock. Like this baby also received a fluid bolus for shock. So coming to another baby, this is again a term baby, 2.2 kg, V3 mother, vaginal delivery, booked pregnancy. This baby went home, came back to the hospital at day 5 of life, admitted to NICU or SNCU with respiratory distress. So baby has fever for 3 days and not accepting feeds for 1 day and started on CPAP, right? So again, TABC maintained, baby warmed, started on CPAP, heart rate normal, CFT normal, peripheral pulses are well palpable. So baby is not in shock. So what should we do next? Should we start antibiotics? Should we send sepsis screen and wait? So what should we do first? Should we wait or start antibiotics after sending culture and sepsis screen? Yes, you can type in your answers. Baby coming from home with fever. Very good. Sahana says send culture, do LP and start antibiotics. Okay, Dr. Aishwarya, send culture and start antibiotics. Good, excellent. Okay, so like pointed out by many of them. So this is a late onset sepsis. So we do blood culture and we also do CSF because chance of meningitis is very high in late onset sepsis, right? Okay. So sepsis screen sent, blood culture taken, LP done. So X-ray shows pneumonia, right? So it is probably community acquired pneumonia. CSF is normal, right? So sepsis screen is again positive. ALC, TLC, ANC, and CRP microASR all are positive, right? So now blood culture is showing E. coli and sensitive to amikacin. So this baby has pneumonia. Blood culture is positive for E. coli and CSF is clear. So what is the duration of antibiotics for this baby? Okay, Dr. Shobha, 14 days. 14 days. Very good. Excellent. So the duration of antibiotics in this baby will be 14 days because culture is positive for E. coli. Gram-negative infection we treat for 2 weeks, right? So what about feeding? So if the baby is hemodynamically stable, then we can continue feeds through OG. If the baby doesn't have oxygen requirement, then we can continue breastfeeding also if there is no tachypnea, right? So baby received CPAP for day 4 and day 5 baby is stable. So discharge on day 15 after completion of antibiotics, right? So the important learning is like you all pointed out, blood culture should be sent before starting antibiotics. Lumbar puncture is important in all cases of LONS or all cases of late onset sepsis, wherever you are starting antibiotics, right? Right. Okay. So now once we have looked at all these scenarios, now we will see how to prevent infection, right? Because treating sepsis is very costly. So parents have to stay for a whole period in the hospital. Antibiotics are costly. Supportive treatment requires respiratory support, ventilator, warmer. So all this is costly. So we should aim at prevention of infection, right? So if at all we consider all the interventions, one of the most important intervention is hand washing or hand hygiene, right? And keep our environment clean, not just the nursery environment, but also the labor room environment, right? So just because we are pediatricians or neonatologists, our job is not limited to the NICU. We should also take care of birthing areas and labor rooms, delivery areas, right? Water is very important. Stagnant water has been known to cause epidemics of many organisms like Pseudomonas. So there should be adequate ventilation and cross ventilation, maintain room temperature correctly, avoid overcrowding, and maintain strict asepsis during procedures. Minimize invasive interventions and needle pricks, and reduce the duration of IV fluids and initiate early enteral fix. Minimizing interventions is very important because at NICU there are so many people who are handling the neonates. So there is a junior resident or JR, there is a senior doctor, there may be a nurse. So whenever possible, talk to the team members and try to club all interventions at a single time. So if the doctor wants to do some procedure, talk to the nurse. Do you want to do some other procedure to the baby? We can combine it in the same setting. If the nurse wants to change the diaper, she can ask the doctor whether the doctor wants to check a sugar or wants to put an IV line. So talk to the team members and make sure we combine all the interventions at a single setting rather than handling the baby very frequently, right? So coming to the key behaviors one by one. So in addition to hand hygiene, environmental and equipment cleanness, healthcare waste management is also important, right? So we all know the 6 steps of hand hygiene, right? So can anybody say how long should we continue hand hygiene for? What is the recommended duration of hand hygiene by WHO? 30 seconds. Okay. Any other answer? 21 minute. Okay, good. So the correct answer is 1 minute. So hand hygiene should be for 1 minute, but in between patient, you use hand rub for 30 seconds, right? So the usual duration is 1 minute. So we have 6 steps. So in 60 seconds, we have to do each step for 10 seconds. So how do you ensure that you do it? Always you count, right? Whenever you do the first step, count within yourself 1 to 10. Again, in the second step, you count 1 to 10. Throughout the steps, you count 1 to 10, right? So in case there is a first thing would be to have a digital clock by the side of hand washing stations so that we are oriented towards the time to up to which we are doing hand hygiene or hand washing. Okay, again, these are the 5 moments of hand hygiene. So there are 6 steps and 5 moments. 5 moments are before touching patient, after touching patient, before aseptic procedure, after touching blood and body fluids, and after coming into contact with the patient surroundings. So can anybody tell which moment is most often missed by most doctors and nurses among the 5 moments? After which or before which step people forget to do hand hygiene out of these 5? Yeah, moment 5. Excellent, excellent. Very good. So we usually forget to do hand hygiene after touching the patient surroundings. So we should always be aware that patient surroundings are also, we should assume that it is contaminated and we should do hand hygiene. So, so there is, we follow bundled approach or bundle care approach. So asepsis bundle should be followed. So it should be at birth, during transport, inside NICU, right? So at birth, you all know about the 5 cleans, right? Clean cord, clean cutting instrument, clean ligature, clean delivery surface, right? So we follow all those things. During transport, we make sure that temperature is normal because hypothermia also predisposes to infection. Inside NICU, take care of the baby, take care of the environment, and take care of the equipment and consumables, right? So warmer, incubator, tubes and lines. These are very important. Like feeding tube, IV cannula, IV fluids, medication, parental nutrition, central line, suction. So all tubes and lines we have to take care, environment we have to take care, and the equipment we have to take care. We make sure that all these are followed correctly, right? So at birth, we discussed now clean area, visitation equipment should be kept sterile, keep the newborn receiving corner warm. So whenever you go to receive a baby, make sure that the room temperature is 26 to 28 degrees Celsius. Avoid unnecessary interventions and initiate breastfeeds as soon as possible for all stable infants. Inside NICU, I think the housekeeping classes were all covered earlier. So we should know what disinfectant to use for each and every equipment and environmental surface. So usually quaternary ammonium compounds, chlorine compounds are compatible with most of the equipment and environmental surfaces. We should avoid stuffed toys and other accessories inside the NICU. And all the disposable items do not reuse, like nebulizer, tubings, water traps, right? So equipment which come into contact with baby very frequently, like ambu bag. Ambu bag is often connected to the endotracheal tube. So all these things, they should be disinfected very carefully, right? And use sterile water for humidifiers and nebulizers. Discard the disposables as soon as used, right? And reusable should be sterilized according to the compatible procedure for reuse, right? And most important thing, procedures are one of the major source of infection. Lines and tubes, we have to take care, right? So there is something called ANTT or aseptic non-touch technique, right? So ANTT means whenever you do a sterile procedure, you do not come into contact with the sterile field in an asterile manner or aseptic manner, right? So wash hands effectively. Do not contaminate key parts, right? For example, if you are going to put umbilical venous catheter, do not touch the tip of the catheter or the tub of the catheter without wearing gloves, right? Like endotracheal tube also, right? All the important parts whichever come into contact with invasion or whichever is going to breach the skin barrier of the baby, do not touch without asepsis. And take infective precautions, right? So always use aseptic fields. Call additional people for help. Do not do all the procedures by yourself. Whenever you do any sterile procedure, be it suctioning, intubation, line insertion, call for additional help. Okay. So another thing is feeding. So breast milk and mother's milk feeding are known to be protective against late onset sepsis. So breast milk, whatever procedure is involving breast milk handling, that should be completely sterile, including storage of breast milk, expression of breast milk, and dispensing of breast milk to the baby, right? So avoid formula feeds as much as possible. If at all, if at all, okay.
You're my website.
Okay. Can you please mute yourselves? Okay, thanks. So avoid formula feeds. If at all it is needed, only make for the feed which is to be given next. Do not prepare in advance and keep it in the room temperature because it is likely to become a source of infection. And there is something called isolation and cohorting. So you all must have worked during COVID. That time there was isolation rooms. So when do we follow isolation? So whenever there is an outbreak with an organism, try to keep these babies in a separate bay. If at all it is not possible to keep in a separate room, at least keep in a separate row or separate bay. So in order to avoid cross infection or horizontal transmission, right? And neonates at risk of acquiring healthcare infection, your very preterm babies, extreme preterm babies, extremely low birth weight babies, try to keep them in a separate bay or separate corner, right? So it may be a challenge in most of our Indian units because of shortage of nurses and shortage of spaces. But whenever possible, try to implement this. So the take-home messages are, so sepsis is a disease which is very costly to treat. So the emphasis should be mainly on prevention. If at all we have sepsis, whenever there is a suspicion, start antibiotics early and also stop early whenever culture is negative or the baby is asymptomatic. Follow antimicrobial stewardship, right? Using the correct antibiotic, correct dose and route, and correct duration. Right? So the key thing is prevention, right? So we are already in an age where antimicrobial resistance is very rampant, right? The WHO says by 2050, most of the deaths, not just in newborns, in adults, in children, the leading cause of death will be antimicrobial resistance. So we are facing an epidemic of antimicrobial resistance. So we should be very cautious about using antibiotics and we should try to prevent infection, right? This is because newborns are the most vulnerable population to infection. So even your small breaches or small unwanted procedures may lead to life-threatening infection, right? As far as possible, remove all the lines and tubes, which includes OG tubes, ET tubes, central lines, and try to promote early enteral nutrition or mother's own milk. Please follow hand hygiene, right? And device-related infection prevention. adherence needs to be there with good aseptic precautions, right? And environmental surveillance. You clean your environment with adequate disinfection. So these are all key steps to avoid infection. Right? So thank you for your patient listening. So if there are any questions, you can put it in the chat box. So are there any questions? Okay, how can I see recording video of this session? I'm not very sure. I think they will post in the group. So if there are no questions, I think we can conclude the session.
So once again, requesting all the delegates, if there are any questions, you can ask directly to sir or write them in the chat box.
Okay, Dr. Rasta Puramat, correct me if I'm wrong, wants to know if there is any difference in term and preterm. Is it related to the clinical presentation of sepsis that you are asking? Okay. So term babies, usually they do not stay in the NICU unless it is any particular reason like malformation, asphyxia. So preterm babies are usually more likely to get infection. So preterm babies all have severe manifestations of sepsis like scleroderma, shock, right, pulmonary hemorrhage. So these things are usually rare in term babies, right? Like instrumental delivery. Do you need to know the risk factor for term babies? Yeah, in term babies, the risk factors more often are maternal chorioamnitis, right? Maternal fever, foul smelling liquor. All these are usually risk factors for early onset sepsis. Late onset sepsis in term babies, if it is a baby already in NICU, it is usually due to a baby with malformation who has undergone surgery, or if a baby is there in the NICU for a long time for some other reason, or ventilated for a long time, like meconium aspiration syndrome. These are the babies who are at risk of late onset sepsis. And other risk factors in babies who go home and come back are faulty feeding, like top milk feeding or faulty practices. So these are the usual risk factors in term babies. As a whole, if you take preterm babies are more likely to have infection than term babies. In term babies, we should consider other things first rather than sepsis unless we have strong risk factors. Instrumental delivery is usually not a risk factor for sepsis unless there are other risk factors like chorioamnitis, foul smelling liquor, prolonged duration of labor, or PROM.
Thank you very much, sir, for addressing the query. If there are any further comments or questions, the delegates, please feel free to ask them to Dr. Murugan, sir, or else you can write them in the chat box. So it seems there are no further questions, sir. So then with all your permission, so we have received one more prolonged
Okay.
labor. One more topic for you, sir.
Okay. Prolonged labor. You mean to know? You mean to ask what is prolonged labor or something? Do we have any suggestion to OBG people? Okay, usually the normal duration of labor in a primary mother, like for the first stage, it is usually around 12 to 14 hours. Second stage should be around 3 hours, right? So in a primary mother, it is anything 18 hours or more is prolonged labor. In a multi-mother, we can usually take the first stage as around 8 hours and second stage as 1 hour. So any 12 hours in a multi-mother should be considered prolonged labor. So the problem with prolonged labor is, why is it a risk factor for infection? The more the duration of labor, the more is going to be the per-vaginal examination or interventions. So that's why prolonged labor is one of the risk factors for early onset sepsis. Any suggestion to OBG people? I am not sure what do you mean by that. But it's important to document I mean, look for labor, duration of labor in the case sheet or ask them so that we know there is a history of prolonged labor. I hope
Thank you, sir.
Cleared.
Thank you very much for addressing all the queries now. So with all your permission, dear doctors, can we close the session over here today? So sir, it seems there are no further queries or comments. Then with all your permission, sir, we are calling it a day today. Goodbye and take care, sir.
Yeah, thank you. Thank you very much.
Thank you very much, sir, for sharing your valuable insights. Looking forward to host you again soon. Thank you, sir.
Sure. Thank you.